Welcome to the Mass Gathering Special Interest Group webinar series for the World Association for Disaster and Emergency Medicine. Tonight we've got some guest speakers, Caren and Kavita from over the border in Australia here in New South Wales, and I'm up here in Queensland. So it's great to have you on board, and thank you so much for coming to do a presentation tonight about City2Surf. A couple of quick housekeeping things throughout the presentation. If you've got some questions that you would like to ask of Caren and Kavita, please feel free to use the question and answer tab in the webinar series. So just down the bottom on your screens where you put the questions for question and answer session. And we hope at the end of the webinar, we'll have some time to answer those particular questions. Throughout the presentation, Caren and Kavita might have some questions which they're going to pose to you. And if that's the case, please feel free to use the chat as you are at the moment as a way to interact and engage with one another in a bit of a social situation. So the chat bit for general conversation and socialization, and then the question and answers if you've got particular questions. So again, welcome to the Mass Gathering Special Interest Group for the World Association for Disaster and Emergency Medicine. I'll now hand over to Caren and Kavita, who are going to talk about the City2Surf. Thank you both.
Thank you. So good morning, good afternoon, good evening. Welcome to this webinar being hosted by us tonight in Sydney. We'll be discussing one of our iconic events. We would like to acknowledge the land of the Wongal clan, which is where we are tonight, and the people of the Eora Nation, and all the Indigenous peoples on the lands that you hail from. This is the start of the City2Surf and what it looks like in the morning. And this is the event that we'll be talking about, and it's taking place this coming weekend. It is actually the world's largest community fun run, and the runners are capped at 90,000 people. The race itself is 14 kilometres from the Sydney Central Business District to the famous Bondi Beach. The race starts at about 7:30 in the morning and has staggered starts, including elite wheelchair runners, elite runners, amateur runners, families and walking participants. This year, there won't be any elite wheelchair athletes because most of them are participating in the 2024 Paris Paralympics. The event has been running since 1971, so this is our 52nd actual run with two virtual years of 2020 and 2021. It's usually run in the middle of August, and it's sponsored by Ironman in the last few years, but previous to that was sponsored by Fairfax News for many, many years. There's lots of community and corporate interest. A lot of charities will use this event for fundraising and gathering community groups together. And you'll hear a little bit about what we call Heartbreak Hill, which is a 2-kilometre ascent, probably about 6 Ks into the race. So that's what the race itself is.
So what do you think about when you need to consider planning for this event? You've heard a few things about it. What would you be looking at in your medical considerations? Is there any impact of it being a mass gathering? Communication, who do we need to communicate to? What do we need to communicate out? What is registration for this event? So how do we know how many runners we're going to have? What is the impact on the local community with the road closures, with transport delays? How do we look at that? And how do we ensure that our emergency services can still have access when we have so many road closures? And what is the biggest medical consideration for this event? So these are just thoughts. I'm happy for you to put things in the chat. Please talk to each other about anything that you think you might have to consider for this event and any brilliant ideas that we might be able to steal for it. So what risks have we identified? Mass casualty event. It's a bit of a no-brainer that it's a mass casualty event. The chance of a mass cas event. Crush at the beginning. So, 90,000 people at the beginning in Bondi on streets coming through. What could that look like if it's early in the piece? What is the impact for everyone else? It never used to be staggered starts, and that's one of the reasons why they've brought in those staggered starts. Vehicles into the crowd. at the start line, throughout the event, at the end. How do they mitigate that? Some of that is through the road closures. What's always in the back of our mind or in the front of our mind is terrorism and an act, whether it be a lone wolf, planned event, whatever it might be. Another significant another risk is the adverse weather. So it could be a hotter than normal day for August or a colder than normal day for August. A big one for us as health professionals is the increased demand on our health services. So that is at our hospitals, but also at our GP practices, our medical centres, and what do we put in place to do that? And then we have to look at the public health considerations that there could be with a lot of people running. So there is significant planning that goes into this event. There's multi-agency planning, but for this slide, I'm just going to talk about the health planning. So we have a lot of health collaboration on this. So ambulance will set up a pre-hospital, they'll pre-deploy resources. They'll set up their command structure, and their command structure work very closely with ours at the finish. St John Ambulance, volunteer organisation, supply over 200 volunteers for this event. They'll have 2 medical teams with that, full capability medical teams, which is 2 doctors, 4 nurses. And they will be deployed throughout the race. So they'll have roving spots where they're actually looking out for people that are looking unwell. They will provide immediate assistance if they need to. And then at the end of the race, they also provide support for minor injuries. Physio, established at the finish line, they support us with our treatment for sprains and strains, anything that's stopping people going to our facilities. Our health response teams, so our health or emergency medical teams come from our local health districts. So our local health districts, we have a number of them throughout the state, and there will be 5 to 8 hospitals. In some districts, there's a lot more. So they will provide teams for this event. But then it's how many teams do we need? What's the composition of the team? Again, 2 doctors, 4 nurses is our standard composition, but it's looking at what do we need? What type of team? Do we need resus capability? Do we need general medical teams? And the big one is how many teams? And throughout the years, as planning for this event has improved, the number of teams we have has decreased, and we'll go into that a little bit later. But with that goes, how are they going to get there? What equipment do they take? Where do they park when they get there? So there is a lot even just in the teams. Then we have to talk to our local hospitals. So we need to make sure that they're prepared for this, with their staffing, have extra staff on in their ED. They have to be ready with their ECMO capability. They have to ensure that ICU has ability to surge if required. Then we look at our liaison in the Emergency Operations Centre. So we'll work under a command structure from health, but we'll also have liaison in a multi-agency Emergency Operations Centre, which is actually called a Government Control Centre for this event. Then there's the public health issues. So we talk about toilets and food standards, which is bread and butter for public health. But we're also talking about, the sanitation and the toilet, the setup at the beginning of the race and at the end of the race. So making sure we have enough for people, for the large numbers, because it's not only 90,000, it's the 90,000 runners, but then there's, all the family that come to cheer them on, the other tents that are set up there, the people at the pubs across the road that are watching the race. And of course, it's at Bondi, so we just got all the tourists there as well. So there's a lot that goes into it. And that also includes looking at what our current infectious disease trends are. So for planning, for multi-agency, it starts around February for this August event. When we're looking at planning again, we've got considerations with our government, local and state government. So there's the street closures that go on. So if you can see in that picture, they've got special buses running, and so they've got to get these out to the members of the public. If you look in the picture again, you'll see the signs to say City2Surf's going on. So the closure of the streets is huge. The sanitation, the cleaning at the start line. So, cold morning, people are there from 7:30, some earlier. They rugged up. What do people at fun runs do and runs do? They strip off and they leave all their clothes, drink bottles, hide them. But who comes through and where does all that go? They need to look at alternate routes, so the transport routes. They've had to look at, the way the run is actually conducted. So it used to come down and you do a big dog leg and you go back, but now they've changed it. They have to liaise with the residents. They have to give them significant notice to say this event is on. Then there's the consideration with the other emergency services. So police with their road closures, how are they restricting access? How are they looking at it from a counter-terrorism perspective? How are they monitoring the front of the run? Fire and rescue, so they help with the bollards, as does the council. State emergency services and Surf Life Saving Australia are other services that provide. So it's making sure that there's enough planning meetings for everyone to be aware of the plan and also be able to come in with what they might want to, if they've got any concerns. So this is an example of the messaging that goes out to the residents. Road closures and special events. So, the road closures aren't just about we're blocking off this road. It's also you now can't park on this road where you would normally park. And the road closures come into effect from 10 to 6 in the morning. So people have to ensure that they've got their cars out the night before, because not many people are going to get up to move their car at that time of the morning. It also goes to how do we get our health teams and all the other support staff through? So then we have to have special parking permits for them to get in. And anyone that knows Bondi Beach knows how expensive parking is anyway and how good the fines are if you're in the wrong place. So we want to make sure that that's available. It's also ensuring that with this, that there's an escalation process for if there's any issues. So the event organisers for this are Ironman. They're responsible for registration. Registration for us is quite important. Everyone gets a number, and with that number, people have to wear their number, and they come in to us as a patient for whatever reason, and we can look up, we can get access to their details, so we can let their next of kin know if we need to, or at least have their name and a little bit more information. They're responsible for sending messaging to participants. So that messaging, there's a lot of health messaging in there. It's about ensuring that you're right to run, you're healthy to run, that you've trained for this event. What does it look like, where you need to be, what your start time is, so what group you're in, where you go, what time the buses that are leaving, how often they leave to get you back out of the venue. And with some of those buses leaving the venue, it can be up to 3-hour line just to get out. They have to liaise with the venues. So it's not just the venues that we use, but it's all the local businesses, ensuring that they're prepared for it. Then they have to look at it, if we're looking at it from a health perspective, they're feeding us. They're ensuring that we have runners that we're supported throughout the event. They have spotters throughout the crowd. They have hydration stations set up. They transport patient belongings. So you can put your belongings in a bag, it's got your number on it, and it will meet you at the finish line in a spot. They produce the medals, they organise the presentations, and the crowd control, which is probably one of the biggest improvements, which is in the staggered starts and finish lines. So I know Kavita said that the elite wheelchair athletes aren't going, but they used to be the first cab off the rank, and they'd be finished before the first runners had even started.
Okay, so we're just going to have a look a little bit more particularly at the health planning. So just a little bit of history about this event. So as I said, it started in 1971, and the first medical support was actually 2 or 3 junior doctors from a local hospital realising the event was taking place and thinking, well, maybe we should just pop down and see if anyone needs any help. It was literally them and a bag. But I guess as emergency and disaster medicine and management has professionalised over time, so too has our response to this event in terms of health. So we send health response teams, and we send 8 of them for a number of reasons. So for us, it's an excellent opportunity to exercise health plan. We have an opportunity to let our teams work in an out-of-hospital environment and to realise that the beds don't go up and down, to realise that, you know, the room is cold or the room is warm or whatever that, you know, it might be. It also gives individuals in the key positions to practice working within the chain of command and to practice using the comms, using the radios, using the NATO phonetic alphabet, because we don't get to do that very often. And then, you know, another event might happen and we suddenly expect people to be experts at something and they've never really had a chance to practice. So we're quite strict during this event to you know, follow the chain of command and to follow the appropriate comms pathways and so on for those reasons. A couple of other reasons why we want to have health teams there, and you can see them listed, but one of the first is obviously to reduce the impact on the health system. So there's 2 or 3 hospitals sort of around the centre of Sydney and then towards the eastern part where these patients would go. And that would be an additional 30 to 50 to more patients on that race day if we weren't there. The other important reason to be there obviously is to be pre-positioned in the event of an alternate event taking place or a deliberate attack on the race. And again, we have these pre-positioned teams who are trained and already mobile, so we can deploy them as needed. One of the other really important reasons is that the early treatment of hyperthermia reduces morbidity and mortality. And if you watch, or if you're ever able to see some of these patients, they come in ataxic, confused, very hypothermic temps of 42, 43 degrees Celsius. If they presented to any hospital, they would be immediately sent to resus and practically being admitted to the ICU. And most of these patients will walk out probably an hour later, clutching their medal, very happy, and go home. And we do have other events that take other types of injuries or things that take place, such as cardiac arrests or musculoskeletal injuries. They're probably the 2 most common, but we have had seizures and other sort of, any illness is able to walk in. The other thing that we try to get our teams to do is to participate in the planning and prep for these sorts of events. So each team is meant to have a pre-race meeting and briefing and understand the plan and make sure that they've checked their equipment, checked their uniforms, make sure that everything's in date, their pharmaceuticals are in date and ready to go. It also gives our staff who have been doing all the training an opportunity to put that theoretical knowledge into practice and to consolidate those skills, to understand what that looks like in the real world, in the real situation. And for particularly the people in the command roles to exercise in that multi-agency sort of way. So we do place our medical commander with the forward ambulance commander the way we would expect that to happen should there be a mass casualty incident. So just building those relationships and letting everyone see what that looks like in real time. So these who is involved. So I think Karen sort of explained most of these groups. So St John's first aid teams, which do include medical teams as well, physiotherapists and some massage therapists, New South Wales Ambulance, we have triage officers, our health response teams. We also have what I've labelled here as New South Wales support. So we have umpires, which we'll explain shortly. We have our state preparedness and response unit who do a lot of the support for the event. Administration support and clerical support. We have the people in the command roles, and we have our logistics team, without whom honestly nothing would happen. And as we said before, we have a health liaison in the government control centre. Just a little bit about what the command structure does look like. So we have a medical commander who has a support officer from the State Preparedness and Response Unit. And we liaise with obviously the forward ambulance command, but also with our health liaison officer, and they can feed our information into the other agencies in that government control centre. Then we have 2 sites. We actually have a surf club site and a scout hall site, each of which has a deputy medical commander. The surf club, being bigger and busier, has also a shadow deputy medical commander because that room has quite a lot of turnover. Both rooms also have a health umpire and another support person from the State Preparedness and Response Unit. The Scout Hall has 3 health response teams, and the surf club has 5.
And just with the response teams, they're a mixture of resus and general teams in both sites.
And then just a little bit about team composition. So each team is 2 doctors, 4 nurses. With our resus team, one of those doctors must be a FACEN, which is an emergency physician with our College of Emergency Medicine. We ask that they're more senior in their postgraduate years, so not a first year doctor, mainly because there's no extra. So, if this person's role is to pop in the cannula and do things, and then they're not yet comfortable or familiar with doing that, there's not another person that can step in. So that person needs to be quite independent. 4 nursing staff on each team. Some of the teams will bring a clerical scribe person, and actually that's a very valuable role because that's one of the biggest parts of keeping all the paperwork and things up to date while freeing up the clinical staff. We have a paediatric team that responds as a general team. They will treat adult patients also, but they like to, again, send their teams to get that experience and training. We ask that all team members have MIMS, which is Major Incident Medical Management Training, and it's really, again, about having that framework of command and control, communication, understanding the concepts of triage, treatment and transport, and then this is them being able to apply those principles in a real world setting.
So if we look at it from a health perspective, how do we pick our teams? EOI goes out to the local health districts. It'll go February, and it'll say, are you prepared to support this event? Because the LHDs pick up the bill for their teams when they send them. So they will identify staff who fit the criteria, and then they will nominate whether they want to, whether they can provide a resus team or a general team. When the LHDs are looking at their team selection, we also have to look at skills. So we don't want to be sending a team out that are all brand new. We want to have a mixture of, I've done it for a couple of years now, so I've been a team leader, I'm going to step back and I'm going to let someone else take that role, but I'm going to support them through the process. And it just means that we're building a bit more resilience within our process and a bit of sustainability. We also, when the teams are selected after the nominations come in, we also have to look at that balancing about the old team, the new team. Is it a team from one hospital? Is that one hospital not only picking up that bill, but are they also depleting their resources? And at the moment, resources are, a little bit more scarce than they have been in previous years. So there's a lot of consideration that goes into it. And there's more of an aim to send a combined team, not from one hospital, but from across the district, which also means that we're sharing some of that understanding and knowledge in it. So where is the event? Well, here's Sydney. It starts at King's Cross, so where that star is, just near there, you'll see Sydney. It will go around the water, past Rose Bay, Vaucluse, down Dover Heights and into Bondi Beach. So as you can see, even just from the roads, they're not straight roads and they're a little bit all over the place. So this is what the run looks like. And this is where the hospitals are. Now, why have we set it out like this? So if there is an issue, or if there's something happens to a patient in the first 5 kilometres of the run, the plan says they will go straight to St Vincent's Hospital. If it happens in the centre of the run, so I'm going to say the next 6 or 7 kilometres, they'll go to the Scout Hall, because the Scout Hall isn't near the end. Now, the Scout Hall has 3 teams, but they also have resus capability. And then the majority of runners will end up at the surf club, which is why we have more teams in the surf club. We say that, but, you know, Murphy's Law, as soon as we think that's what it's going to look like, it will change. But that is pretty much what the plan is.
So this is what the actual, I'll call them medical centres or medical facilities look like. So this is the Bondi Surf Lifesaving Club. It's a very prestigious club. Membership's quite hard to get, and the members are quite possessive of their club. But we've managed to secure it as our venue for quite a few years now. So these are existing buildings. So we use this surf club, and I'll show you in a moment the second facility, which is a scout hall. Obviously, you can see in the background their pictures and their awards, and their boards are still all on the wall. So we use the black sort of sheeting boards to protect their space and allow us to then, they Velcro those black things, so we can stick some of the treatment algorithms on the wall and attach hooks to hang the IV fluid. We've got some beds, but as I said, the bed doesn't go up and down. They're just standard beds. We do have 3 resus beds that we get brought in to each of the centres, so that one bed will be able to go up and down, and the head can be laid flat, and all those sorts of things to assist with intubation. You can sort of see there's some chairs also set out. As the patients improve post-treatment and fluid and so on, they then get set up and asked to drink and make sure that they're no longer ataxic and you know, able to drink and keep the fluid down and coherent and can walk. We've got big waste bins, and obviously we have clinical waste and non-clinical waste, and we do separate those things out. We expect all the standard, you know, universal precautions and usual health protocols still apply. It's basically a healthcare facility. It's a makeshift one, but it is one. We do the bump in on the Saturday, so the day before the event, we will, we being the command team and some of the logistics team, will come and set that space up. And then we do the bump out on the Sunday. So post event, once the teams have been stood down, we'll do the pack up. There is some assistance from Ironman. Obviously, they will bring in some of the products, and we will provide some of the equipment and so on. But we'll show you that. You can see there the space isn't very big, and by the time you add the 5 teams in this room plus a few command people, it fills up very quickly. So you can see on the poster there that it's patients only, partly for privacy as well. Most of those patients, you know, as I said, when they start, they're quite unwell. So we try to keep family and friends out, unless, of course, it's a paediatric patient, just to minimise the people, the noise, and the issues, any issues in the room.
Can I just point out on the right-hand side where the white tent is, that's where St John are. So St John are close, so if any patient deteriorates, they can be moved, or if we think a patient needs to be supervised for a bit longer, but they're quite well, or they've just come in with a sprained ankle and they shouldn't be with us, they can be moved across to St John. So we work very closely with St John.
And then this is the second healthcare facility, and it's a scout hall. So Boy Scouts will be there once a week or whatever and have their meetings and so on. And again, you can see their boards up on the wall. Very simple building, but it's made to fit our purpose as we need on that weekend. Probably the only thing you can see there, which is quite fancy, is the ramp, which we have to add, partly to get ambulance stretchers in or out should we need it. So that's why we had to have a ramp put through so we can get up those stairs. But yeah, these 2 facilities work very, very well.
So when we look at the equipment, we have a standardised equipment list of what people take. They're given to them. There's a few extras that they do. And as Kavita said, Ironman will supply extras. So they'll supply things like the beds, the chemical ice packs, which we go through a significant amount of them because of the way people are presenting. The linen, the thermometers we have to bring. But we also have to ensure that we're looking at our work health and safety. So what are the considerations for chain of custody of our Schedule 8 drugs? How do we transport our oxygen cylinders, which the teams are asked to bring in? How do we secure them in vehicles to bring them in? You know, at the moment with the IV fluid considerations, how much are we actually setting up beforehand? So this will all be, this all goes out to them with things like the fluids that are coming up that will be discussed in the briefing on the day. Over the years, we've worked out that patients are coming in and they're having hypo, so we've had to look at now supplying complex carbohydrates for them, which we never used to before. Sometimes it would be the staff running down to the shop to buy something for them. So, you know, we have improved the process over the years, and that's the good thing. You know, protocols, we have to ensure that we've got the protocols and that we stick to them.
So just a little bit about patient management. So our most common presentation is actually hypothermia, which is surprising given it's in the middle of winter in Sydney. So it's for us, it's quite cold. Probably for the North Americans, not so much. But interestingly, this is our most common presentation. So we have quite a robust process for these patients. Immediate cooling. So we're obviously firstly checking their temperature, immediate cooling with the ice packs in the groin, the axilla, the neck, commencing the IV fluid. So the cannula goes in, fluid goes in. Once you've seen a few of these, they just become very slick at, the teams become very slick at doing it. Interestingly, I've put hypothermia in there, partly because the race ends at Bondi Beach, and many people think it's a great idea to go for a swim after the event. And the Pacific Ocean in the middle of winter is freezing. Well, I think the ocean temperature is, I don't know, 18, 19 degrees. I meant to look it up this morning. 16 degrees, there you go. So that is something that we also potentially have to contend with. Cardiac arrest. So we will have a cardiac arrest, unfortunately, on the race, usually once every 2 or 3 years. Quite often it's a young person with a previously undiagnosed cardiomyopathy or something like that who exerts himself and then unfortunately arrests. We do have, so up until last year, we used to obviously resuscitate the patient and extricate them as quickly as possible to the closest hospital, which is on call for ECMO, and the ICU, and everybody is aware. We actually last year and this year will have ECMO on site, so they will be able to commence ECMO at the site of an arrest. So thankfully last year we didn't have any, so hopefully this year will also be arrest free. Trauma, so as you can appreciate, with that many people sort of running or walking in the same direction, people trip over each other or the footpath or whatever, so you'll get the odd laceration or musculoskeletal injury that needs to come through. We have a bit of a plan with the local pharmacist to get crutches and a pickup spot so people can, you know, so we're not utilising ambulance because somebody's got a sprained ankle and so on. We have the ability to give them imaging request forms, so they don't have to go to the closest hospital. They can go to home and get the images that day and then have appropriate management closer to their home. And hypoglycemia, so as Karen alluded to, a lot of people will most of them do have some breakfast, but a lot of them seem to become hypoglycemic. We fix it, then they have a sort of second episode of hypoglycemia. So we really realise that we need to give them some complex carbs once we realise that's what's going on. And obviously with all of this, we have the algorithms and we'll be following the Australian Resuscitation Council guidelines for cardiac arrest. So nothing has changed. We've just taken the health teams to a more expedient location for the patients.
So if we look at the patient journey on the course, and it doesn't matter whether they are a runner or a non-runner, they will still follow this journey. So interestingly, we had a 90-something-year-old woman that was found unresponsive at the bus stop waiting for the bus, and she got absorbed into the process. So they're identified. First response is medical retrieval team or the St John's. St John ambulance, they'll scoop team. New South Wales ambulance will triage them and transport them across to New South Wales Health, to wherever they are, depending on which part of the race they're in. They will be treated by New South Wales Health in one of our 2 sites, and then they will be transported to hospital if required or discharged, as Kavita discussed. Runner collapses on Heartbreak Hill, exactly the same thing. Now we know that they're going to the Scout Hall. New South Wales Health resus team will treat the patient. The patient remains confused after our interventions. And then a decision will be made whether they're going to be transported. Now, there is a protocol about how many bags of fluid, how long, what their temperature has dropped to before the decision is made to transport them or discharge them home if they've improved. At the finish line, again, they're identified, they're picked up by a New South Wales ambulance. They could have been identified by St John, who might have picked them up, or it's New South Wales ambulance, and they will go to a health team, they'll go to St John, or they'll go to the physio, depending on what their needs are. And again, if they need it, they will be transported to hospital. Can I just talk about Heartbreak Hill for a second? Heartbreak Hill, where the residents are restricted in their movement, they actually have parties on the hill. So you will be running past and they'll be having champagne breakfast. They also will hose runners down as they're running if it's a hot day. So, you know, we talk about spontaneous volunteers. They're actually helping us keep our patients down a little bit, but they're also creating a trip hazard because now the roads are slippery.
Okay, so a little bit about race day, which, as I said, will be this Sunday coming. The shifts are long, so most of the teams will probably get to their hospital. They'll all meet at their base hospital about 5:30 in the morning, because they need to be in at the centre by, I think it's by 6:30, and after that
10 to 6.
the roads will close.
Yeah, the roads are closing earlier this year, so teams have to be in place by 10 to 6.
So yeah, so that's the difficulty. We identify one team in each of the sites to be what we call our late stand down teams. So when we think, you know, we get information that the last run has crossed a certain point, we think, okay, we can start to sort of stand people down. We do that sort of in a gradual way, but we always leave one team still ready, because we very often get a last minute person come rushing through, and often they're quite unwell. So we've learned that we need to keep one team available. We tend to pick a team that's not the furthest away in distance, just out of courtesy to the other teams. Documentation. So we have some pre-formatted patient forms. Those documents are scanned and saved, and should a patient be transported to hospital, they are copied and sent with the patient. On that, we are able to document their observations, their clinical findings, any management initiated fluids, and their progress. So you can sort of track their blood pressure and their temperature and so on, depending on how it's needed to be. If a patient is sent home, they're given a discharge letter, a pre-formatted discharge letter, which they can then take to their general practitioner, which explains that they were treated in one of the medical centres, what they were treated for, and what, if anything, needs to be followed up. It might be for removal of sutures or something like that. If a patient is being transported to hospital, the medical team will hand over to the ambulance officers that will be transporting that patient, who will then take those notes and the patient and hand over to the relevant treating team at the hospital that they're taken to. In terms of briefings, we brief with the command team on the Saturday, the day before the event, to make sure everybody in those key positions is aware of who is who and what role each of you has, and how things are going to work. And then there's a briefing on the Sunday morning with all of the teams to go over any new events, be it the IV fluid shortage and how we're going to manage that, be it, you know, will we be wearing masks in the facility or not, or depending on whatever the new pieces of information might be, we will discuss those at the briefing. And as Karen said, so generally at the event, you'll have about half of the health response teams, some of the members that have never been, and about half who've been a few times. And that's actually quite a good mix, because it allows people that ability to come and participate and watch and see the other teams and see other people and learn from them. And I can see it year after year that they do, without feeling pressured because they don't know how to set up, or they don't know how, you know, what's going to happen. Meals are provided. So obviously we encourage staff to have some breakfast before they come, but lunch is provided. There is parking, but it's not for everybody. So what we do is we ask the teams to come as a team, so that they will get one team bus or one team van parking spot, as opposed to the 6 team members each getting a parking spot. As you can appreciate, it's very tight at the end. The command team will get also parking at the medical facility. Site access. So this is one of our biggest problems because, as Caren said, there are often a lot of functions and charity events and all sorts of things going on, and people are used to walking through certain ways to get to where they want to go. And suddenly this is now a health facility with patients and patient privacy and patient confidentiality and all of those sorts of issues that we need to take into consideration. And so they can't access, or they know that there's a toilet in there and they don't want to use the Portaloo. So we have to be quite strict about the access into our facilities. And then with regards to uniforms, again, it's for identification. It's to allow staff to get comfortable in what they wear should they be deployed. There's visibility and it's suitable for the elements basically. So those are really important. We also wear a tabard over the top with the roles inserted so people can see who is who in a team. All staff must have their identification, their staff identification as well, so that we know who they are and what their role is and what their skill set is. Time. So yeah, so early is the basic answer to that. Early start, and usually we can't leave till at least 4 o'clock. And again, it's about the roads being reopened and the crowd that's sort of in that space. So it is a long day. Transport to the site. So as we've said, we encourage, the teams have to come as a team. It's really important. They are paid for this shift, and the New South Wales local health districts are actually the ones that pay for that shift. It's not a voluntary event, like they have to be paid. That also ensures that they're insured for this shift as well. And in terms of breaks, we do rotate them to go and have breaks. So when they get there and set up, we sort of roll them to go and get coffee and have a bit of a look around and see what's going on before the briefing. And then once the briefing started, we kind of get everybody in and get them settled, ready to go. Was this me? So we decided before, I forgot. So education. So the elite athletes, as you can probably appreciate, are very unlikely to be the ones that we see. So there's sort of that very excited beginning of the race, and then a little bit of not much happening because those aren't the patients that we get to see. We generally see the sort of and in the last few years, we've taken to utilising that downtime to do some education, getting people in the rooms to give their experiences and so on, making sure that people didn't just sit around and get bored, but reinforcing that the teams understood why they had been deployed, what they were there for, what could happen, what might happen, what they should be thinking about, what they should be preparing for. And there's sort of two aspects to it. One is we have some pre-prepared sort of Q&A type things, and we get each group to do one of the scenarios and present it to the rest of the group. But two is we get them to simulate, if a patient came in, where's the, where are the drugs, where's the ECG dots, where's the laryngoscope, where's the endotracheal tube. So just getting them used to that space and where their equipment is and who's in their team and who are they working with. So we really have picked up on this education piece in the last couple of years.
So we're just going to talk about the health umpires that are supporting this event. So most of the time, well, all of the time, they're a senior clinician. They do have an educational role in that they're the ones that lead the education session that Kavita just spoke to. But we do a really good audit, and the audit is on, you've deployed a team, but now we want to know what their skills are, how they were picked, what issues they had coming, have they all done the training that we've required of them? Are they working as a team? We all know that when we deploy with people, we don't always like everyone. So are they functioning as a team? Do we need to step in? Are they in the right equipment? So they take on a safety role. Have they got the right shoes on? Are they in their, the appropriate uniforms? The umpires have a lot of that. They'll provide some clinical support. So their eyes and ears for the deputy commanders or the commander in the room. They will, if they're needed in a resus, they'll go and jump in if they're needed to. And the reason we use the umpire and not another team is because if we get another patient, we've still got a full team that can support that other patient. So the umpires can jump in, and being that second pair of eyes just helps with us understanding what's going on in the room. The coordination centre, so the government coordination centre, we've already mentioned that we have a health liaison in there. It's multi-agency. It coordinates our activities. We provide regular briefings to it on what we're seeing, any issues we're having. Again, we've talked about traffic management in here because that is significant. So it's not only are we having traffic management plans at the event, but if one of the local hospitals is having problems getting through, or there's a community or an outreach team that can't get to their patient, that will go up through the coordination centre, through the liaison officer, and we'll try and rectify that problem. Sometimes it's even they won't let our health team through in the morning. We've had where they've been stuck and they've been told, no, it's closed, but they've got all the right paperwork. So it's looking at it. They're also there in case anything else goes on. And, you know, it's good to practice in that multi-agency setting anyway, and give people an understanding of how health works, because everyone thinks they know how we work and what we do. Our liaison officer will work very closely with the ambulance liaison officer in there.
And then just a little bit more about the logistics. So this team, honestly, I can't emphasize enough how essential they are to the smooth running of this event. Obviously involved heavily in the bump in and bump out and the setting up of the medical centres. They will be involved from months before in terms of ordering equipment, making sure that it's very clear what Ironman is going to provide, what they will be providing, and what the health teams will be providing, so that there's no sort of misunderstanding or miscommunication. They'll utilise some of the state medical cash if needed. So, for example, last year we had an issue with the beds not quite being ordered correctly and not having enough. So we utilised some of our medical cache of NATO stretchers, and we use those in this setting. And again, it's just an opportunity for those teams to see, okay, this is stuff that we would use. Should we be deployed? Should there be a field hospital, and so on? And the logistics team were all over being able to access that and sort it out. I've written there this sort of MacGyver on the day. So anything that pops up, someone's brought something and it doesn't work, they'll somehow jimmy it and fix it and make it work. One team's forgotten they brought their glucometer, but they've forgotten the blood sugar strips. Okay, we'll get you some of those. So they just always sort of put out those little spot fires. They're always involved with the site visits to make sure that nothing's changed with the venues, that someone hasn't suddenly added another step or ramp or something that we are unaware of. They're often makeshift security and assisting with lifting, moving, that sort of things. They'll run things for us between the two sites, because as you can probably appreciate, once that race starts, it's very difficult to get across the road. There's thousands of people coming at you. So it's really difficult to get across any roads. So they can sometimes get across should we need it to. And they're always watching out for the OH&S standards. So you'll see them with the tape, making sure we don't trip over wires and cords and things like that. So yeah, very, very important role, very important team. And then we just have a little bit of data about a couple of the last couple of years. So City2Surf 2019 was actually quite cold. It was 15 degrees and quite cloudy. That year we had 20 patients. Only 6 were heat related, with 5 transports. A lot of hypoglycemia and musculoskeletal things and back pain. But you'll sort of appreciate as we get hotter. So this City2Surf 2022 was 18 and clear. 26 patients treated, 13 heat related, and that's only 3 degrees different. Probably was less windy on this day as well. This year we had the out of hospital cardiac arrest, who was transported directly to hospital for an angio. Chest pain, asthma and head injury were some of the other things that we saw there. 2023, so this year it was 21 and sunny, so we've had 35 patients treated, 14 heat related, 6 transports. A couple of syncopes and chest pain needing transport. So obviously just bearing in mind that we have no imaging and no pathology at the medical centres. So we were able to do a 12-lead ECG on our transport monitoring, but we can't really do any more imaging than that, other than a blood sugar. Any more investigation than that, than a blood sugar. But you can appreciate just from, I think that's the only 3 years we put in, but that's from those 3 years of data, that the hotter it is, the more patients we will see. It's almost inevitable that there's a direct link between the two. And I think that was all that we wanted to talk to you about. Obviously, we're very happy to be contacted or spoken to, and our email addresses are there, but we'll hand back over to Jamie.
Yeah, thank you both. Really informative presentation. I've got a couple of questions already online, so I might just ask you about some of those things. And the first one's to do with who pays for the health services, which often comes up in the mass gathering context about who's going to pay. So how much are the organisers paying for the extra cost of health services, or is it burdened by government who pays for it? Who's paying for the extra services?
They do pay for ambulance. They will pay for ambulance. And as we said, they do pay for some of the consumables. They'll pay for the fluid. They'll pay for getting the beds in. They'll pay for the ice packs. They pay for the meals. So there is some cost borne by them. But in terms of the staff salary and those sorts of things, New South Wales Health will pay for that. You might think, well, why? But I think that sort of first or second slide that we talked to about the opportunity to exercise and the opportunity for staff to practice some of their theoretical education is enough for New South Wales Health to say, okay, yes, we value this opportunity.
Thank you. Next question's about risk assessment. Do you use any risk assessment tools? Like WHO recently have published a number of mass gathering risk assessment tools. Do you use any of those to help in planning your events?
Yeah, we do, Jamie, but it's a multi-agency. So we are using one of those tools.
Okay, and you mentioned some of the previous year's data. Are you using that data to help inform this year's event that's coming up?
Yeah, so every year
expecting anything different?
No, it's really interesting. We're just trying to work out how many years we've done this, and I think this is going to be my 20th year. So every year we will have a debrief. Every team will write a report. We go through all those reports, thoroughly. Each year we'll make a modification, be it what equipment we take, and things have changed over time. We take an ECIO now. We take just other pieces of equipment. I can't even think of a good example at this moment, but each time we read the reports, we say, okay, yes, that's probably something we should add, but we can't just keep adding. We sometimes have to take off. You can't keep just bringing more and more and more. So we have to be a bit sensible about what we do. We've really streamlined the pharmaceuticals, I think, quite a lot. That was certainly something we went through a couple of years ago and really did a big streamline of that.
Even the number of teams we take. So it used to be 14, 15 teams, and now we've got it down to 8.
And then, we were almost thinking a year or two ago, should we have 7? But and then obviously we've added ECMO in the last 2 years. So it absolutely evolves over time. And each time we think, okay, what else could we change or do if we need to?
Yeah, brilliant. In case of needing to cancel the event, so often some major events get cancelled for various reasons, and perhaps due to extreme weather conditions might be one of those. What's the health input into that, or who's responsible for making such decisions?
Yeah, so that will be multi-agency. It wouldn't just be health input, it would be multi-agency. That would be a difficult decision.
But just as an example, so this race had been capped at 85,000 for probably 20 years, and this year the event organisers asked to go up to 90,000. They went to each agency, so they spoke to police about what the implications for them would be. They spoke to ambulance, what would the implications for you be? They've spoken to us and asked what would the implications for you be. So they actually have to go around and sort of speak with everybody to understand all the perspectives and then make a decision based on that.
Question about your involvement in other events and perhaps any international events. Do you guys take the lessons learned from here and apply those to other contexts?
So our other biggest events were music festivals, and
that's why we're laughing.
So music festivals, unfortunately, a couple of years back, and again, I think very temperature related. Temperature and drug related, drug use related. But the hotter the day of the event, the more deaths we were seeing and the more
presentations.
more seriously unwell people, we were seeing. So we were actually sent out to, we had a sequence of music festivals with some very adverse outcomes. I think maybe 5 or 6 in a row with very adverse outcomes. So we were sent out to have a look at the next one, which just happened to be in our local health district, to have a look what was happening. So we went that morning strictly in an observing role, watching the briefings, watching the, looking at the setup, looking at the public health facilities in terms of toilets and water availability and all of those things. And that day I think it was 30+ degrees at 9 o'clock in the morning. So already it started very hot. And unfortunately, these events, this was a festival that went on from 11 a.m. to 11 p.m. So 12 hours in the baking sun. So unsurprisingly, there were lots of presentations, and sadly, there was also a patient who was deceased at that festival.
From that festival.
We recognised that she was very unwell. We got her transported out very quickly, but she still did pass away from the both drugs and being so hyperthermic. So that led to a whole body of work in terms of sending teams to these events. Very similar things, sending a health response team, supported by our retrieval colleagues. And the very first event that we sent our team to, there was 5 intubations, but no deaths. So, and that sort of progressed that whole summer, really, that whole festival season. We had 5 intubations, 6 intubations, 4 intubations, and no deaths. And we had our ICU prepared to accept the patients. Very quick turnaround. And it was interesting, the difference it made to the hospital, so to the emergency department in particular, because the patients came in a lot more sorted. So even though, if I said to you, I'm sending in 5 tube patients on your shift, you'd be like, oh my God, that's crazy. But they actually got processed very, very quickly, as opposed to the 1 or 2 that we sent from the very first festival that had no health no health response team there. Very different. Those patients really consumed resources, whilst the ones that had the teams on site, much easier to manage.
Yeah, the hierarchy of clinical care from first aid through to ICU, and everyone having an understanding of their role and that it may happen and expect it to happen, versus an event where it just happens out of the blue and people start turning up. And whilst you've got a hierarchy of clinical care, it's not as prepared and organised and expecting different outcomes for sure. Yeah. A couple more questions just as we start to wrap up here. One from Ali around communication between your different sites. So you've got a number of different sites. How do you guys communicate between one another in case you need, different resources?
We have radios, and we have our mobile phone as our backup. And we also use Microsoft Teams to communicate with our health liaison person in the control centre. So we, pre their meeting, we'll text them how many patients in each site, what sort of pathology we have, if we have any transports, and so on. And then as the medical commander, I will communicate with the forward ambulance commander directly. Like, we sort of sit together basically.
Equipment wise, you mentioned ECMO on site. Do you do point of care testing of other pathology or?
No, so it's honestly a 12-lead ECG and a blood sugar.
Okay. That was an easy one to answer. A bit more complex, drones. A number of agencies use drones for different things. Do you get intel from other agencies who may be using drones to get a sense about participant movement or other insights? Or does that just come through your operations centre?
Yeah, that will come through the GCC and through our LO.
Yeah, so they'll speak to us. But it's interesting. So you saw in a couple of slides that I think we mentioned spotters twice. And what you're looking for is someone who starts to wobble. You can see them, they're running, and they start to wobble and suddenly they go down. It takes experience to be a good spotter, but I guess what you're asking is, can drones do that? And I guess the answer is yes, they probably can, but you'd need someone watching the footage who can recognise the wobble.
Last series of questions before we wrap up here. Thanks everyone for your time. Terrorist attacks, CBRN type incidents. You mentioned very early on that you do risk assessment, and those things were high up on your list. What about volumes of patients and the ability to expand, or specialist skills for those particular things on site? Do you want to make a final comment just about those?
So from a CBRN perspective, fire and rescue would lead that decon. That would not be us in the pre-hospital. Our role would be very much away from that in the nice safe zone. And part of that is that not all our teams are trained for that. Not all our team members are. Our hospitals are equipped to be able to respond to that. So the plan would be for them to be deconned on site. We are very guided by police and counterterrorism into what they're expecting and what they would want of us.
And then just to your question there about patient numbers, should they be higher? So we do have, I think, capacity within those teams. So we have got 2 doctors, 4 nurses, and they're 2 very senior doctors and 4 very senior nurses, and they can split into extras, which is why we encourage the teams to bring a scribe, because it allows the clinicians to be clinicians. Yeah.
And each team doesn't get 1 bed either.
They have four beds.
Each team gets 4 beds.
Yeah. And you get some, assumably, sift and sort through the St John ambulance teams that are on site and the New South Wales ambulance that are on site. So it's not just you having to manage particular incidents, it's a multi-staged approach to that, which is. Well, we might wrap up there, and thanks very much both for your contribution and your insights into your event. I hope it all goes well. The next one coming up very shortly. We might wrap up there from the Mass Gathering Special Interest Group for the World Association for Disaster Emergency Medicine. Thank you so much for listening and contributing in questions. The presentation, as Andrew mentioned, should be live shortly and recorded and sent out in an email with a link for you to be able to access the presentation. Thank you both again.
Thank you.